Hi, I'm Dr. Henderson McGinnis, emergency physician, talking about pericardiocentesis. Cardiac tamponade is a rare but life-threatening condition. Tamponade results from pericardial effusion that compromises hemodynamics. We will be reviewing emergent pericardiocentesis for hemodynamically unstable patients. We will not discuss diagnostic pericardiocentesis. There are many causes of pericardial effusion, and not all result in tamponade. Only when the effusion compromises hemodynamics do you consider the need for emergent pericardiocentesis. The diagnosis of cardiac tamponade. You have to look for it before you can treat it. Consider tamponade in your patients who are at increased risk of pericardial effusion, those with renal disease, malignancy, and some autoimmune disorders. You can also have traumatic tamponade from penetrating trauma, but these patients may be more obvious with a history of penetrating trauma or a sign of penetrating trauma to the torso, and they will likely benefit more from an open thoracotomy than from pericardiocentesis. The classical teaching for diagnosis of cardiac tamponade was Beck's triad, JVD, hypotension, and distant heart sounds. If you are waiting for your patient to develop these symptoms, you may miss patients with tamponade. The most common clinical signs of tamponade are dyspnea and chest pain. These signs are very nonspecific and they do not necessarily point you toward tamponade. You need to have a high suspicion for cardiac tamponade to diagnose it. You should consider tamponade in all of your patients with PEA and look for it with bedside ultrasound or attempt pericardiocentesis. The diagnosis of pericardial effusion or cardiac tamponade has been made much easier with bedside emergency ultrasound. Treatment of cardiac tamponade with emergent pericardiocentesis. This is usually an emergent procedure and not generally done as an elective procedure for diagnostic purposes. The recommended technique is with ultrasound guidance, although many times this procedure will be done blindly. There is also a technique for attaching an EKG lead to the needle as you perform the procedure. The benefit of doing the procedure is return of spontaneous circulation. In general, we do not perform diagnostic pericardiocentesis in the emergency department. The risks of the procedure are damage to the liver, the lung, diaphragm, GI tract, and the heart itself. Assemble proper equipment and maintain sterile technique. Identify your landmarks. Find the left costoxiphoid margin for the procedure and clean the anterior chest and upper abdomen with betadine, chloroprep, or other cleansers. Draping of the patient will not be done to better demonstrate landmarks. You may elevate the patient 30 to 45 degrees, but this is not often done in code situations. If using ultrasound, you locate the largest effusion and direct the needle toward that area. If a blind approach, you will locate the left costoxiphoid margin, insert the lumbar puncture needle with the stylet in place into the subcutaneous tissue at a 45-degree angle to the skin. If using a regular needle from a central line kit, you will want to have a small amount of sterile saline in the syringe to get rid of the skin plug. Attach the syringe and aspirate as you advance the needle toward the left shoulder. Look for return of fluid when you enter the pericardial space. Also look for return of vitals. You may not need to draw off a significant amount of fluid to see a return of vital signs. If you do not have CT surgery on site, you may want to insert a triple lumen catheter into the pericardium using the Seldinger technique after you get return of spontaneous circulation to facilitate the removal of more fluid and to reduce the risk of damage to the heart with the needle. This is where it is easier if you've used the central line kit for the procedure to start with. Following the procedure, if you have return of spontaneous circulation, continue to monitor for changes in vital signs and reaccumulation of fluid. Consult CT surgery and arrange transport if necessary. You may secure the catheter if placed. Perform normal wound care and observe for complications from the procedure.